muscles, I'm also thinking about the coughing muscles. So yeah, we got the diaphragm, that's the big one. We got the intercostal muscles, and there's intercostal muscles on the inside and intercostal muscles on the outside. And what's weird is that the external intercostals assist with inhalation, and the internal intercostals assist with exhalation, and specifically forceful exhalation. And then you have a whole bunch of accessory muscles that can help you when you're distressed. Two of the big ones are the scalene muscles and the sternocleidomastoid, and they're kind of up in this area, and what they do is they pull your rib cage up, basically, and assist with bringing that air in. And then the big one for me, and it's the one that tons of people don't think about, especially doctors, and it drives me nuts when they're thinking about extubating a spinal cord injury patient, is the abdominal wall muscles. The abdominal wall muscles aid your diaphragm, but not in the way you think. We'll go over that in a little bit. You need good abdominal wall tone in order for your diaphragm to work properly. But think about when you cough. When you cough and put your hand on your stomach, you can feel your abdominal muscles flex. So if you don't have abdominal muscles, if you don't have abdominal wall tone, you will not have a fully intact cough. So that's a big one. So, what nerves are we talking about here? So the big one is the phrenic nerve. That's the one that innervates the diaphragm. And it originates from C4. I guess real quick we should go over, right, you have 7 cervical vertebrae. So when I say C4, I mean the 4th cervical vertebra. So you have 7 of those. You have 12 thoracic vertebrae. You have like 5 or 6 lumbar vertebrae, and then you have your sacral segments as well down there. So it's kind of divided up into 3 points. So diaphragm originates from C4, but receives contributions from C3 and C5. Have you heard the rhyme about the diaphragm?
C3 to C5, keep the diaphragm clear.
Excellent. Yeah. So as long as C3 is intact, your diaphragm will work, albeit not at full capacity, but as long as you have C3 working, you're good. Anything higher than that, would be considered ventilator dependent. Your diaphragm does not work. So your thoracic intercostal nerves, they innervate your internal and external intercostals. They are from T1 to T6. So if you have an injury in that area, you have lost the ability to innervate all or some of your external intercostals, or internal and external intercostals. That has implications not so much for regular tidal volume breathing, but it does have implications for distressed breathing, exercise, all that kind of stuff. And then you have a couple nerves. One's called the thoracoabdominal nerve and the subcostal nerves. They innervate the abdominal wall muscles, so T7 to T12. So in that area, you start to think about your ability to take a deep breath might be okay, but the ability to cough is not going to be as strong as it And just the other muscles we talked about, the scalene muscles, some of your accessory muscles, that's at C4, C5, C6. And your sternocleidomastoid muscle is actually a cranial nerve, so that will still work even if you're a C1. It'll still work because it comes from the brainstem, but you still won't be able to breathe because your sternocleidomastoid won't be able to do enough to actually create negative pressure in the thorax to get air in. So yeah, diaphragm, primary, C3, C4, C5, keeps the diaphragm alive. Intercostal muscles, T1 to T6. Abdominal wall, T7 to T12. And abdominal wall, coughing, forced exhalation. You're gonna need those in order for it to happen. I'll have people, they'll be thinking about extubating a spinal cord injury patient, and they'll say, oh, he's got a great NIF and a great vital capacity. A couple things we'll talk about later, but they'll say, do they have a cough? Oh, they have a great cough, because they have the reflex to cough. They have the reflex to cough. They will make the motions of a cough. But I'll tell them, put the suction catheter down their ET tube, put your hand on their stomach, and suction. Does the abdominal wall stay flaccid? Then they do not have a cough, at least not a very effective one. And with the internal intercostals, the ones that assist with exhalation, normally exhalation is passive, right? You're not using muscles to exhale. That's more of like a forceful, when you're forcefully exhaling or you're coughing, something like that. So here's just a diagram that just kind of gives you a look, a snapshot of what's going on. On the left you have the inspiratory muscles and where that's all being innervated. And on the right, you have your expiratory muscles where those are being innervated. So the higher up you go, the more likely you're going to have deficits in both, in inspiratory and expiratory. The lower you go, the more likely it is you're just going to have a trouble with your cough. So, real quick, how does breath get in? Well, your diaphragm contracts and your thoracic cavity expands, and air is drawn into the lungs. And when I say drawn into the lungs, it's not, you're not pulling air in, right? It's a negative, you create a negative pressure environment, right? And air wants to go, and, gases want to go from high pressure to low pressure. So you create a low pressure environment in your lungs, and so everything goes in. When your diaphragm relaxes, the thoracic wall recoils, and air leaves the lungs because you've created a higher pressure environment in your thorax than what is outside. So pretty simple. And we call this, right, negative pressure breathing, which is kind of an aside, but when we talk about like ventilators, and ventilators is not negative pressure breathing, right? Positive pressure breathing. And they talk about how can we make ventilators more comfortable and more natural and all this stuff. You can only get so far. Ventilators are not natural, they're not comfortable. They are positive pressure breathing. The body is just not built to do that, especially for extended lengths of time. Pushing pressure into the lungs, that's why we worry so much about peak pressure and static pressures and all that kind of stuff, and pressure differential, because the lungs just can't take that for too much of it for very long. So here's just another picture. Diaphragm pulls up, pulls down, intercostals pull up, air is drawn into the lungs, diaphragm relax, intercostal muscles relax, air goes out. So the ones that I'm really looking at in spinal cord injury patients, for the most part, is actually their vital capacity. How much can they take all the way in, and how much can they go all the way out? So that's a test we'll do when we're thinking about, is somebody able to be extubated versus do we have to do a slow wean? Are they going to be vent dependent? The vital capacity is one of the things we look at. Do you know what kind of device we use for a vital capacity at the bedside?
A respirator or the.
Yeah, there's a specific name for it.
It's like
Wrights
the what do you
barometer.
It's a Wrights, yeah. Yeah. You know how much they cost? They're like $5,000 a piece, and basically we break them all the time at Harborview, because if they do a forced vital capacity through a Wrights respirometer, they will destroy it, because you have to do a slow vital capacity because the inside mechanisms are just not built to deal with that. Huh?
Controlled breathing.
Yeah, so basically what I want to do, I want to do a slow vital capacity where I want to tell them, okay, take as big of a breath as you can take all the way in, and then slowly exhale it all the way out. So just, and just keep going, keep going, keep going, keep going, keep going. It's different than a forced vital capacity. Who am I doing a forced vital capacity? Yeah, asthma, all that kind of stuff. Because when you do a FVC, you're looking to see if the airways collapse under that turbulent airflow, so all that kind of stuff. Yeah. So vital capacity, speaking of, it's the maximum amount of air that can be exhaled after a maximum inhalation. So here's one of the answers here. Actually, both of the answers that I asked earlier. So when you're doing a vital capacity, or like working hard, 70% about, give or take, is done by the diaphragm, and 30% is done by the external intercostals. And a normal value between 2 to 5 liters per minute. That's about 50 to 70 mLs per kg is normal. And when I say per kilogram, do I mean actual body weight or predicted body weight? Predicted, yeah. Because the lungs are the same size whether you're 5'5" and 100 pounds or 5'5" and 500 pounds. Lungs are the same size. And the critical value that we're looking for is about, depending on what book you read, about 10 to 15 mLs per kg. At Harborview, depending on what doctor is going, they might, weaning is acceptable at 10, some want them to get up to 15 mLs per kg. I will say this, vital capacity is really hard to get an intubated spinal cord injury patient to do, because they have a total just muscle weakness, loss or weakness of their diaphragm, and they're getting these nice big breaths from the ventilator, and then you take them off and you say, breathe as hard as you can, or take a big breath and exhale it all out. They don't want to do that. You've basically taken their breath away, and instead what you get is you put the respirometer on them and they go because they're scared. And so what you have to do is you kind of have to talk to them about it. You take them off, you let them hyperventilate for a sec, you put them back on the ventilator, and you're like, okay, I am here with you. That was scary. Let's try this again. And you try and just work through it and get them to the point of, it takes a lot of trust. And sometimes you got to take them off the vent, have them feel distressed for a sec, put them back on the vent so that they know that you're going to be there for them and get them put on. So ideally usually you get a vital capacity, but a lot of times it's just they're too panicked to be able to get properly. And you do it later while they're maybe in the middle of their weaning. So tidal volume, right? Normal amount of air on inhalation and exhalation with normal effort. Looking about 7 mLs per kg in an average person. And 90% of that is done by the diaphragm. Depending on the book, 90 to 95%. The intercostals help a little bit, but for the most part, it's all diaphragm. Has anyone, who's here has been to Harborview? Did anyone get to go down to the ER when they had an open thoracotomy, or what we call a cracked chest, where they open up the chest cavity?
No, but I want to.
Well, it usually means a bad day for somebody.
Well, of course.
But if the patient were to unfortunately pass away, it's a good opportunity to actually get to feel the diaphragm. It's actually, you get to feel how it's a very strong muscle. And usually there's I don't know, as respectful as possible, but there's usually a line of medical students and some RTs and stuff who they will let you kind of reach in to the thoracotomy site and feel the diaphragm, and it is a very strong muscle. It just gives you an idea of how powerful it is, and it's constantly working, right? It never takes a break, so it's always in peak condition. So then the other thing I do, which is really easy to do, is the NIF. It's totally scary for the patient to do this, but it's easy to do. They don't have to follow really any directions because they're trying to generate pressure against a closed airway. So you're putting something on them and they're sucking in and they're not getting any breath. And you're trying to see how far they can pull the needle down. It corresponds with respiratory muscle function and strength. They say a normal value is -60, but we're gonna, later on this quarter, we're all gonna do a NIF. And the other day I did a NIF on myself, and without even trying, barely, I was hitting a -120, -150. So, the critical value that we say someone cannot breathe on their own for any extended period of time is -20. I want you guys to do a NIF at some point this quarter, just to see how profoundly weak you have to be to only generate -20. Because I bet most of us will be able to easily get -60, if not -100, -150. Just to give an idea, like just how hard it is. So the old school way of doing a NIF, they used to do the NIFs at night at Harborview. So they would come in while the patients were sleeping, take them off their ventilators and put them on a NIF manometer, and they would wake up not being able to breathe and just trying to generate pressure. We don't do that anymore. Now I tell them about it and what we're doing and how it's going to work, but I will give them a full 30 seconds to a minute of trying to generate pressure. Because sometimes it takes a while. We want to see a really forceful breath. So at first they might be pulling -10, -10, -10, -10 over and over and over again. And as they get more distressed, we see -20, -30. So I pre-oxygenate them. I suction them out beforehand. I leave them on 100% for a few minutes just to get them real good. I make sure I have a good view of the heart monitor and the O2 saturation monitor. I take them off, put them on the NIF, and I will let them go for 30 seconds to a minute. Usually you're seeing their eyes kind of bug out. What I was taught was that you didn't do a proper NIF unless they desaturate and go bradycardic, which we don't do anymore. But I will let them get down to about 90% before I stop, just because I want to see a good, true pull. And it's sometimes it takes them, because they haven't been breathing on their own for a while, sometimes it takes a little bit of distress to get to that point. So it's a little mean, but it's what you gotta do sometimes. Mechanics of cough. So, our diaphragm and our external intercostal muscles, they contract. We take a deep breath in and air rushes into the lungs. And then we close our glottis, we close our vocal cords, and we trap all that air. So those are two things that they have to do right there. They have to be able to take a huge breath. They have to be able to close their glottis, close their vocal cords. Sorry, that one's a little tiny, but so you breath in and you close your vocal cords and you start to bear down, and then your abdominal muscles and your internal intercostal muscles, they contract. So your abdominal muscles push up and your external or your internal intercostals pull the rib cage down. And this increases pressure in the lungs because you have your glottis closed and you have everything squishing that rib cage down, building up pressure. And then we relax our vocal cords and we expel everything. So that's how a cough works. Now I can actually measure cough velocity. I can use a peak flow meter to measure cough, to get a surrogate of what cough velocity is going to be. What do I normally use peak flow for? Asthma, yeah. So I can get a peak flow meter and I can have them do a peak flow, and that'll give me a general sense of what their cough velocity is going to be. They say you need it about 160 liters a minute to be effective. And anything under 270 liters a minute, you're at risk for retained secretions. It'll just give us an idea. This is hard to do while they're intubated. Really impossible to do while they're intubated. You have to do it while they're, once they've been extubated, basically. But it gives you an idea of what kind of therapies you're going to need to utilize in order to help them with secretion clearance, which is a huge thing. So, if you are C1 to C2, you have complete paralysis of the respiratory muscles, and you are ventilator dependent for life. Absent cough, no cough. Now there's all sorts of crazy, amazing, radical therapies happening right now, none of which are done in the state of Washington. I think the nearest place you would have to go is either Stanford or UCLA, but there's some stem cell treatment, there's some weird treatment they're doing with virtual reality. I'll try and explain it, but they hook all these electrodes up to you, and they're using this more for arms at the moment and fingers, but they hook all these electrodes up to you, and then they put to your head and your arms, and they put some virtual reality glasses on you, and you think about moving your arm, and the thought of moving your arm creates an image in the virtual reality of an arm being lifted. And I guess over the course of several months of doing this, they're starting to see the neurons like recreate connections just from like seeing it happen and thinking it and all that kind of stuff. But very, very experimental, very far away. You could also do something called diaphragmatic pacing, which is not done here. The one place I know that they do it is at a place called Craig in Denver. It's like the foremost spinal cord injury rehab place in the country. And what they do is they open you up, basically from brainstem to diaphragm, and line electrodes along your phrenic nerve and along your diaphragm. It's a very dangerous procedure because if they nick the phrenic nerve, you're done. There's no coming back from that. very dangerous procedure, but if it works, then you basically have to wear this massive backpack, and it will send electrical pulses into your diaphragm and make it contract for you. I have one patient who last I heard she was in Denver and she had this done. She was a C1, ventilator dependent. She was, I believe, ejected from a vehicle. And she was 23 years old, C1, completely ventilator dependent. And when she was done with rehab in Seattle, her parents raised a bunch of money, flew her to Craig, and she had that done. And now, last I heard, which was about a year ago, I don't have an update, but she was off the vent during the day, but on the vent at night, which is huge, to be able to be free of the ventilator and be able to not be chained to that. And so that was huge for her. C3, C6, you have variable impairment of the respiratory muscles. Everybody kind of reacts different in that regard. In the acute phase, your vital capacity is going to be about 20% of normal, give or take. Most we can get weaned over time. It takes some time, but most of them we can get that. But still an absent cough, so they're going to need secretion clearance assistance. C7 to T1, respiratory muscles are pretty much intact for the most part. Vital capacity, 30 to 50%, 60 to 7% in the long term, and you're kind of getting still usually an absent cough, but getting into that weak cough kind of phase, where you can maybe do some muscle strengthening and get to a point of coughing on your own at some point. T2 to T5, our respiratory muscles are intact. Our vital capacity in the long term is close to normal. Weak to fair cough. I have a guy right now, he's a T8. So he's here. I have a guy right now, he's a T8. His respiratory muscles are intact. He's got a good vital capacity. His cough, I'm going to say, is more weak than fair, but it's getting stronger. He's getting there. This patient I'm working with right now, since this is the last slide of this, and then we'll take a break. My current patient down in rehab, he is a T8 Asia A. We'll talk about the Asia scale maybe next PowerPoint. We'll talk about the Asia score in a little bit, but it's a way to score the severity. Asia A means complete. He's a T8 Asia A. The problem is he's also 80 years old, so he's got a lot of things working against him, and you know, as you get older, things don't heal as well, things are a little weaker, all that kind of stuff. Somebody in their 20s, if they were a T8 Asia A, they probably wouldn't need to do any ventilator weaning. We'd probably just be able to extubate them, and we'd just have to support them with cough. But he's had to do extended ventilator weans just because he's so weak. He's a little older. And then the bummer is that a couple days ago, he got a chest CT, and they noticed a bunch of pulmonary nodules in his lungs. So what could pulmonary nodules be?
Cancer. Or TB.
Yeah. Yeah. All those things. Unfortunately, they think it's cancer. But it could be TB, could be like interstitial lung disease, could be cancer. Unfortunately, they think it's cancer, and so I guess he had a history of thyroid cancer, got radiated. They think he's gotten metastatic cancer in his lungs now, which is great. It's totally sarcastic, because he's 80 years old. He's going to be a paraplegic at best, and he's got lung cancer, and it's metastatic. So that sucks. He also has this interesting thing that when he desaturates, he doesn't care. When people desaturate, they usually get some sort of distress, right? And they turn blue, and they start breathing fast, and they get loopy and weird, and they get distressed, and all that kind of stuff. He gets blue, but he doesn't start breathing fast, he doesn't feel distressed, and he doesn't know that he is desaturating. And that is because, I think, this is what the pulmonary doctors think as well, in your neck, there are chemoreceptors in your carotid bodies. They are one of the areas where your body senses your oxygen level and your carbon dioxide level. There's some in your brainstem, some in your carotid bodies. Well, they think that when he got radiation there, it destroyed those chemoreceptors. So he has no chemoreceptors left to tell him that his oxygen's low. So he'll be in there and he'll be alarming, 88, 85, 80%. His lips are gray, he's blue. And he'll be like, "Hey, John," and he'll go, "Hello, how are you?" Just smiling, happy, no idea that he's desaturating. So that's another wrinkle that we're trying to deal with him, is that he also doesn't sense when he's hypercarbic. He doesn't start to breathe fast. He doesn't feel short of breath or anything like that because the radiation destroyed his chemoreceptors in his carotid bodies. Wild. I have never experienced that before, so yeah. But hopefully, I have a couple days off. I'm going back on Friday, and I'm hoping he's like near off the ventilator when I get back. So let's take a break. Let's go